Hi, welcome back everybody. It's 4:30. We have to start the next session. So I request the chairpersons, Dr. Ajit Desai sir, Dr. Yunus Loya sir, to start a very exciting interventional session, and please carry things forward. Thanks.
Yeah, I think we will start with the session on intervention and ischemic heart disease. There's a slight change in the order. Dr. Rajiv Bhagwat is going to talk first, and that is what is the new in management of bifurcation lesions.
Chairman, dear friends. So, bifurcation is one subset in interventional cardiology which is still dynamic. So, though nothing much has changed in the last decade, but there are a few techniques undergoing refinement. So, one such is the decay crush technique. So, there is a small step that has been added to the decay crush. It's called proximal side branch optimization. That basically stems from the fact that the ostium of the side branch is always larger than the side branch size. Now, how do you measure the ostium? The ostium is measured from the bifurcation point, 3 to 5 millimeters from the bifurcation point. The ostium of the side branch is always an oval structure. It is never a fully circular structure. That's the reason why it has a little larger diameter. So this is the classical decay crush technique, which I don't want to elaborate further. I will go next. So this is what happens when you stent the side branch. This is how it looks. You see the side branch edges are not fully approximated. And when you crush the stent, this is what it looks like in the central illustration. So the end result is like this. So you lift up the metal from the carina, and that is where you are prone to cause some restenosis, ISR. So the PSO, what it does, it ensures stent size, larger stent size, vessel diameter, proximal strength, better strut position to the wall. And as a result, it helps you to increase the space for wiring, and the guide wire advancement into the side branch is more assured. This is what happens. If you see the first two pictures, the stent is still hanging at the ostium, and the side branch, and see the wire, how it goes. The wire can go under the stent, through the strut. You're not really sure on fluoroscopy. And this is what happens when you optimize the ostial stent deployment. This can happen with a compliant balloon or a non-compliant balloon. And this is how it looks when you crush with the balloon. There is full contact at the ostium. So this is a step that has been introduced in the last couple of years. This we were actually practicing much earlier, but we didn't present this. And in fact, we presented this in the EBC of 2017, but we didn't think that this is really worth mentioning as a separate paper. So I think we missed it. Then, which strategy? Provisional is making a comeback, and the prelude to this provisional approach with these trials, the Nordic, the Cactus, BBC, all the bifurcation trials in Europe have been biased towards provisional. Europe is one area which is completely biased towards provisional, and the only two-stent technique they advocate is the culotte technique. Till the decay crush trial data was out, and the prelude ended in with the introduction of the EBC main trial. So somehow or the other, they have found that the two-stent strategies have not been as good as provisional. Decay crush to some extent has dented their claim, where in simple and complex lesions, both Shaolin Chen has found to be superior to provisional and other techniques. So EBC main was basically designed with a provisional approach and a systematic approach, a two-stent strategy. Very surprising, they have asked or allowed the operator to still continue with TAP and T. TAP and T were abandoned by EBC in 2018 in the Porto conference. They said we no more recommend T and TAP, and still they allowed the operators to do T and TAP as a crossover in the systematic two-stent approach. So these results, they've 1 year result said the stepwise provisional was superior to two-stent strategy. And though there were 22% patients who underwent a second stent, and the 3-year results also show that the stepwise provisional was superior. Here, the primary endpoints were achieved much later with the provisional approach, and the target vessel revasc also was superior in the provisional approach. So, as per EBC recommendations, stepwise provisional should remain the approach of choice for majority of left-brain bifurcation interventions, though 1/5 of these patients required a second stent. Although in complex bifurcations, DK crush should remain the strategy of choice. DK crush as a strategy of choice is a recommendation of ESC. Or ESC and EBC they are not on the same page. There was a big debate in one of the meetings that we attended a few years ago. And when one of the Indian presenters said ESC recommends DK crush, the entire EBC got up and they said, no, this is not our recommendation. So in Europe also there is a division. So this is one of the few cases that we did provision. This is a lady with anterior MI, LV dysfunction. We put a balloon pump and she presented late. So we did a deferred stenting of the left main ostium. And this is just one stent, provisional. This was an IVUS guided intervention. And there was a minor dissection left at the ostium of the ramus. If you see the last picture, there is a minor dissection there, but this was a IVUS assisted intervention, so we could leave it alone. There was no luminal compromise, and we could achieve a excellent result. This is another patient which was not IVUS guided. This was done about 8 years ago, and there was a plaque straddling the trifurcation. Here also we could get away with one stent at the trifurcation. Then comes drug-eluting balloons, which I have found newfound confidence in the European operators. Drug-eluting balloons were introduced somewhere in the mid-2000s, 2005. They first came on the scene, approximately that time. And at that time, the drug-coating balloons, the drug concentrations and the deliverability, I would say, there was so much drug on the balloon that there was no consensus what should be the approach. And it was only paclitaxel. The original balloons were Elutax, which we used in a fair number of patients, but they're very difficult to track, those balloons. So now there is a newfound, I would say, love for drug, especially in Europe, and the operator who is advocating this is Dr. Antonio Colombo. Principally, it is drug-coated balloon is without a stent and a polymer versus a drug-eluting polymer, drug-eluting stent. The drug-eluting stent has a slow release kinetics. The drug-eluting balloon has an immediate release. This immediate release kinetics also differs with paclitaxel and sirolimus. Paclitaxel is a little faster release, sirolimus is a little longer release. And of course, the dose also varies. And the most important thing, there is no polymer. So there were a host of trials between 2008 and 16 with various combinations, DB with BMS versus DES, small vessels. Then there was a meta-analysis which was mostly with paclitaxel coated sequent please balloons. And this trial first gave an indication that DB can be a standalone device for coronary bifurcations. This is a very interesting slide where a good number of operators are concerned about the dissections that happen when we are using a DEB. So in this, it's a little complex slide, but if you see the red dot indicates type C dissection. There were 5 patients, of which 2 remained type C, and then with treatment, with further balloon dilatation, there was no dissection in 3 of them. The blue dot is type B dissections, where 1 continued to be type B, and the orange dot is a type A dissection, where just 2 remained in type B. Surprisingly, if you see the analysis, there have been no cardiac deaths in these patients. So as the standard teaching goes, for usage of DEB, you just need good basics, prepare the bed well. There is no specific strategy as such. So DEB has a newfound approach for treating bifurcations. There are various protocols being formulated as of today. So DEB only for side branches. But this is a little controversial thing. The last EBC meeting, we discussed with the EBC members and the operators. They recommend use of DEB in a side branch after stent deployment. Now this would definitely, if you don't open the side branch osteum very well, you're liable, you're possibly going to scrape the drug off the drug-coated balloon. So that is the problem. So we use, in our usage, I use the DEB first and then send the main branch, and then we handle dissections or recrossing the side branch as is. Another approach of a kissing balloon DEB, which is fraught with some problems, because when you have two circular objects together, then it gives you an oval disposition where there could be areas in the bifurcation which are going to be untouched by the drug. There is going to be drug loss as well as reduced contact over here. So which drug in the drug-coated balloon again is a problem. So the latest or the transform trial in the last ECD meeting was a very clear-cut positive impact of the paclitaxel coated sequent please balloon versus magic touch. Now there is after this trial, the B. Brown company itself has got a sirolimus coated balloon. So now the next trial which is possibly going to be there is the Transform 2 trial, which will give us the answer, because there is going to be a head-to-head versus the paclitaxel versus the sirolimus coated balloon from the same company. This is one patient where we used a DEB recently, had acute coronary syndrome. We called him for a staged procedure, and we used a DEB, and you see the large circumflex. We could end up opening all the branches. And we then use a ramus for we use a DEB for the ramus with a good result. So DEB for restenosis is there to stay. For de novo lesions making a comeback. The new trials, the ongoing trials, the solution is a new sirolimus coated balloon, and the transform will define the role. Paclitaxel plus BMS is inferior to DES. Can the DEB replace DES is a $1 billion question, because with short DAPT and effective DES usage, I think that's going to be a challenge. BOSS technique is our homegrown technique, which we have presented in the EBC 2017. This stems from the fact that we are not able to do a perfect tap most of the time. It's principally because there is continuous cardiac motion at the angles. So this is a animation which I have very often. Ajit, give me another minute. So we first stent the main branch, then we block the main branch with a nominal balloon with the side branch stent in place. We go up on a small pressure in the main branch balloon, say about 2 to 4 atmospheres. We pull the side branch stent with this inflated stent. We see it approximates the main branch balloon, and then start inflating the side branch stent, simultaneously going up with the main branch balloon to nominal pressures. Narrow angle, we did this patient, and you see this is where we blocked the main branch, and you see how we pull the side branch stent. And that is where we start deploying with an excellent result. This patient was confirmed with an IVUS, and if you see this picture, there is an excellent deployment here with a wide lumen in the main branch. Anterior MI, failed thrombolysis. We stented the left main. There was a dissection at the ostium circumflex. We tried to open the strut, and we had a good result.
Dr. Bhagwat.
Yeah, let's go through it.
Dr. Bhagwat.
And last, I will finish with a decay culotte. As we have double kissing crush, we have a double kissing culotte. The reason, when you have a single kissing culotte, you end up lifting the stent over here. And this is where there is the bench testing studies have found to be having a very circular lumen with double kissing versus a single kiss culotte. And I would end with this. These are flow dynamic studies where you see there is, in a decay culotte, is almost good laminar flow with hardly any eddy currents, and the other eddy currents where there is a risk of ISR. Thank you.
Thank you, Dr. Bhagwat. I think we can join.